Good morning, Director Ma'am, respected teachers and my colleagues. I'm going to give a case presentation which was done in our institute, in our department, with distraction, osteogenesis and mandible. Definition, just a brief introduction about the distraction. What is distraction? There is a biologic process of new bone formation between the surfaces of the bone segments, which are separated by incremental traction. And this distraction forces, when it is applied to the bone, it causes the surrounding tissues, the tension around the surrounding tissues, which gives a sequential adaptive changes, which is the term distraction osteogenesis. And then the biological principles, as we all know, it was given by Ilirezu, and there are two effects, which is tension stress effect and the influence of blood supply. This tension, it can stimulate and maintain the regeneration of the growth, and it can cause the distraction. This is what the tension causes the bone formation, and also the influence of blood supply. If the more blood supply is there, then only the growth can happen. If not, the growth can hamper. And then indications in maxillofacial surgery, when we have to do the distraction osteogenesis, when we need an advancement of maxilla or the mandible which is greater than 7 millimeter, and in TMJ ankylosis, where we have the patient's mandibular growth has been impeded, and then when there is obstructive sleep apnea, within the obstructive sleep apnea, if the mandible is being taken forward, if there is a retruded mandible, it can be definitely life-saving to the patient, and correction of facial symmetry. And when there is inadequate mandibular anatomy, and there are secondary mandibular advancements when it is needed, and also facial advancements in syndromic patients like Perry-Robin sequence and Sickler syndrome. This has been definitely a life-saving. Distraction of mandible has been life-saving in Perry-Robin sequence, and also in Sickler syndrome in the neonates and in the infants. And then if we just give about a brief about the distraction devices of which are available in the craniofacial, maxillofacial area, it can be an external or an internal distractor. External are bone-borne distractor, and the internal distractor, it can be subcutaneous or intraoral. And intraoral, it can be submucosal or extramucosal. And the distraction, it can be unidirectional, bidirectional, multidirectional. Unidirectional distractor, they give the growth only in one direction, either the vertical lengthening of the ramus, or the body can be lengthened in horizontally, or it can be bidirectional, where both vertical and horizontal components are at rest, and the multidirectional, where completely we need three-dimensional movement or three-dimensional growth of the mandible. That can be happened in the multidirectional distractors. And then stages of the distraction osteogenesis, osteotomy, it is just a cut which we give to separate the bone so that the inflammatory process can be started for the growth of, for the formation of the bone. This latency period is the one where we have to wait from the osteotomy and the distracted phase, where the bone formation, before the bone formation we have a callus formation, and after which the distraction can be started. This distraction, it has to be predetermined how much amount we have to distract the mandible or the maxilla or any structure, and then we have to wait for the consolidation period where the bone formation occurs, and then the remodeling. This remodeling phase, it is there till 1 year. The research says it is till complete 1 year the bone takes to remodel, after which distraction has stopped. And then we have to go for our case presentation. 11-year-old female reported to our OPD with a chief complaint of reduced mouth opening and inability to eat since the past 7 years. She gave a history of trauma, fall from height, over a chin when she was 4-year-old, and she did not report any significant medical history, neither her parents report, and she was in her prepubertal phase. This growth has to be considered, because this if the child is in prepubertal phase, the growth can also occur fastly. And then the patient, this was her intraoral nil mouth opening is being shown to the patient, and patient has shown to multiple hospitals, and then she reported to our OPD. And immediately after she reported, the clinical problems which we could elicit was a reduced mouth opening. The patient had mandibular retronathia. I am just going to the picture once again. There are patients having mandibular retronathia. Mandible is being placed for backward, and also retrogenia is there for the patient, and the patient's mother also gave the history. She had a history of snoring almost every day, And then the patient's dental midline are not coinciding. The maxillary and mandibular midline, they are not coinciding. And then these are the clinical problems which we have to address. And we have started with the routine radiographs. We took orthophantomogram. This orthophantomogram, if we see the patient orthophantomogram shows a permanent dentation with bilaterally. If we see there are a bony mass over the condyle, which is being fused in the TMJ region, temporomandibular joint region, and the articular space is almost nil. And then we proceeded with her lateral cephalogram. In the lateral cephalogram, we had to do the marking of the lateral cephalogram for the analysis to measure what is the mandibular body length, what is the airway space for the patient, posterior airway space, and then we have to also see the facial convexity. So if we measure the body length and body ramal height. This is how we measure the mandibular ramal height, which is measured from the condylion, which is the superiormost point in the mandibular condyle, till the gonion, and the mandibular body we have to measure from the gonion till the pogonion. And then the cephalometric analysis was done, which after the analysis we could elicit the mandibular ramal height was small and the body length was also small, and the patient had the retruded chin with there is a decreased pharyngeal airway space both upper and lower. And then we proceeded with her NCCT phase for the patient. In the NCCT phase, this is the axial section and this is the coronal section. If we see, again there is a bony mass over the TMJ region with an interarticular space which has been obliterated bilaterally, which is suggestive of the TMJ ankylosis. And then this is a three-dimensional view which has been done for the patient. The bilateral TMJ fusion has been depicted here. And then since the patient gave a history of snoring, we had to do the sleep scales also. In the sleep scale, we did the Epworth scale and the Berlin's questionnaire. In the Epworth scale, the patient had a 2 out of 10 of score, where the patient gave a history of sleep when she is after her lunch. And when the patient also gave a history of sleep when she is driving in a car without a break for half an hour. And in the Berlin questionnaire, the category 2 and 3 were 0, nothing of the questions were positive. And in category 1, it was 4 upon 6. So since only one category was positive, it showed her low risk of having sleep apnea. And then we did a sleep study, polysomnography was done here with the sleep efficiency was 97.5%. And the patient's AHI index was very high, 50.5 per hour. For her age, for the pediatric, more than 11 to 15 is itself severe, and it is 50.5 was the AHI index for her. And the respiratory index was 50.5. And she also had a very high snoring index of 248.2 per hour. And then we had to formulate a surgical plan. Before formulating the surgical plan, we had to, the DICOM files were sent to a biomedical engineer, and where virtually surgical planning was done. And then three-dimensional stereolithographic model was printed, where we planned in the osteotomy cuts were planned in that. And then the surgical plan which we planned was the TMJ ankylosis was released simultaneously along with the distraction of the mandible. This is very important because if the distraction is not being done, if the mandible is not being considered to bring it forward, the mandible can fall back, and this can cause a disastrous complication to the patient, which may even lead to airway compromise and tracheostomy. So the mandible should also be considered for the patient. For this patient, we plan simultaneously distraction and also ankylosis. And these are the blood investigations, routine investigations, which showed no abnormality almost. And then this was the virtual planning, where we can have all the teeth, and we can also, very importantly, we get the inferior alveolar nerve landmark, because this is very important when we place the distractor. We should not injure the nerve, and the teeth are also, and also the developing third molars are also there. So when we give an osteotomy cut, we have to plan in such a way that we don't injure any of the teeth or the nerve. And this was the planning which we got. And in the model, we did the osteotomy planning, where we have to place the pins and where the osteotomy cut we have to give. When we plan for the osteotomy cut, we have to also make sure we don't disturb the mandibular angle, and because this angle is very important for the patient's aesthetics, and we don't disturb the inferior alveolar nerve. This marking is also here.
Just move a little away from the mic.
Yes, sir. Yes, sir. We should also plan for the inferior alveolar nerve marking, and where we have to place the distractor pins and the osteotomy cut also, so that we don't injure the hard tissue, the soft tissue, and also the nerve. And then these are the distractors which were placed for the patient. External distractor with a Shen pin of 2 millimeter thickness. And then the distractor was placed in the 3-dimensional model, and the stent which was placed was also taken intraoperatively to decide where the distractor have to be placed. And then the pin placement was also planned pre-operatively. We have to place simultaneously. We have to place in proximal and distal segment, the distractor pins have to be placed. And then when we plan for the ankylosis release, there are various incisions in the historically, right from the pre-auricular and alkylar Bramley incision. In the alkylar Bramley, which is more commonly used, we have the incision is very large, which is starting from the scalp area and which is going till the pre-auricular area. Then we plan for the invisible incision. It is just the incision. It is just an incision. It is just over the tragal cartilage. The incision is given, and so that we can expose the TMJ and we can do the surgery, and the patient will also have very less scar and also almost a nil scar as well. And this is the intraoperative picture. If we see, the abdominal graft was also interposed after the condylar mass was resected. The abdominal graft was interposed because the patient should not have any recurrence of ankylosis, and the incision is so small and we can get a very wide exposure as well. And these are the intraoperative picture. We also place a distractor for the patient, and also the ankylosis release was done simultaneously. And then immediate pictures. This is the immediate picture of the patient. If we can see here, it is just this very small incision. Through this very small incision, we could get a beautiful exposure of the entire TMJ. And this is the immediate post-operative picture of the patient. And the site of graft, the abdominal graft, it was also just a periumbilical incision, which is very minimally invasive, and it was also healed. And then distraction protocol which we followed, we started after 5 days of latency period for the patient, and 1 mm of distraction was planned every day for the patient, with this 0.5 mm twice daily, morning and evening, at an interval of about 12 hours exactly. And on right side we could achieve a distraction of 15 millimeter, and on left side which is 14.5 millimeter. So after the distraction, we had to also do the callus molding. This is because if the teeth have not been addressed, if the mandible is coming more forward, and it can hinder the occlusion can hinder the mandibular movement, and the distraction could not be achieved. The desired amount of distraction could not be achieved. So for this reason, we placed an elastics between the upper teeth and the lower teeth, so that we could differentially mold superiorly and inferiorly, so that even if the mandible is moving forward, the teeth are not being we could get the optimal overjet and overbite which we need to get. And then this is what we have discussed, the cuspal remodeling. If we could see here, we placed a posterior occlusal stop over here, so that the mandible is free to move, the distraction is not being hindered. And then these are the serial radiographs of the patients. If we could see, is the preoperative radiograph with the TMJ ankylosis, and this is post 1 week of the patient where the distraction, after the distraction has been just started. And this is, if we can see here, after 2 or 3 weeks, after the complete distraction has been achieved bilaterally, and this is just before the distractor removal, where the callus has been formed. And this is the cephalogram of the patient which was pre-operatively, and this is the post-operatively. If we could see, yes, the mandible which was retrognathic is now being in the position, and the pharyngeal airway space is also being addressed here. The upper and lower, it has been better, and also the mandible has moved forward, and the patient is also having the TMJ ankylosis release has also been done. This is the post-operative and the pre-operative picture of the patient, frontal view, and this is the profile and side views, and this is the mouth opening currently of the patient of 35 millimeter. And if we see the advantages, the patient had got a simultaneous surgery of both TMJ release and the distractor placement, and this is very much advantageous because the patient need not have the trauma of 2 times intubation, and we also did a proper planning so that patient did not have any inferior alveolar paresthesia, she did not have any injury to any tooth, and she is comfortable now. And these are the serial photographs of the patient starting from the preoperative of the patient. And I just wanted to discuss 2 cases of the internal distractors also which placed in our department. 8-year-old patient who gave a history of middle ear infection. Her mother gave a history of middle ear infection when she was 8 days old. And then since 1 year she had a gradual reduction in mouth opening. When she reported to us, she had a nil mouth opening. Here we have the bilateral, we have the TMJ ankylosis where panoramic radiograph shows the bilaterally there is it is a mixed dentition and there is bilateral articular space obliteration and bilateral condylar fusion in the TMJ and also enlarged coronoid process. And if we see the cephalogram, again there is a pharyngeal airway space is restricted with the mandible placed backwards in this retrognathic mandible. And for her, since the deformity was too much, we had to plan for the distractor first, and then when after the distraction and after the mandible has come forward, plan for the TMJ ankylosis release. This is the CT of the patient where the bilaterally there is articular space, this is the coronal section, this is the axial section, and bilateral intra-articular space obliteration has been there with condylar fusion showing of TMJ ankylosis bilaterally. And then this is the intraoperative pictures, we place the internal distractors, and this is the postoperative picture of the patient. And these are the serial radiographs with the preoperative until the distractor removal and the ankylosis release. This is the distraction day 0 and after the consolidation and the ankylosis release. So this is also the lateral cephalogram. Again, if we see here, we could see the mandible has come forward in and also the pharyngeal airway space has been improved much better. The space in the pharyngeal airway space has also improved much better. And this is the serial pre-operative and pre-distractor removal photograph of the patient. And the patient is currently under follow-up both the patients are undergoing orthodontic treatment to do the minor occlusal changes also. And this is a 4-year-old patient who did not give any history of infection or any trauma. The patient had a gradual reduction in mouth opening since when he was 1 year old to a nil mouth opening again when he reported to us. And for this, this is the radiograph, panoramic radiograph and the cephalometric radiograph which we could take for the patient. And if we see the patient is having a primary dentition and in the left side there is an articular space obliteration along with the fusion of the condyle with the temporal bone showing of TMJ ankylosis, with there is enlarged coronoid process as well. And then for the patient, these are the serial radiographs before the distraction is being, when the distraction was being done. And this is also the serial lateral cephalogram. If we could see, again the lateral pharyngeal space, upper and lower, it has much improved for the patient. And also the mandible has come forward from here and it also come till here. And these are the post-operative radiograph for the patient with the distractor in situ and the frontal picture. The patient's consolidation period is being, after the consolidation period, he is planned for the distractor removal and the TMJ release. And conclusion, yes, the distraction osteogenesis can correct the facial deformity and also the mandibular insufficiency. And it is definitely a life-saving procedure in many situations. And it can also alleviate the functional and cosmetic problems, uplifting the quality of life. Thank you.